like to invite Dr. Somnath Noshkar, eminent consultant practicing in Howrah. He is also associate professor of SSKM Hospital. And there is another chairperson, Dr. S.K. Somani, an eminent neurologist. He will join us shortly. I would like to request Dr. Somnath Noshkar to please take over the seat and introduce our speaker.
Good afternoon, everyone. So we are concerned about the complications of diabetes, starting from neuropathy, nephropathy, and retinopathy. So diabetic neuropathy is one of the common complications, and the spectrum ranges, starting from peripheral neuropathy to autonomic neuropathy. So it's a whole lot of very common and irritating signs and symptoms. So to discuss about this, we have our speaker, Professor Dr. Ramesh Bhattacharya, who is Professor, Department of Neurology, Calcutta National Medical College and Hospital, and his area of interest is headache and neuropathic pain. He has 20 publications in both national and international journals, and he has authored 8 books. So without wasting much time, sir, floor is all yours.
Good afternoon, everyone. It is a great privilege to be here for Diabetic Society in Howrah. They are organizing, last year I also came here and gave a talk. Now, this time, diabetic autonomic neuropathy, one of the most important and serious complication of diabetes mellitus. Next. Operate here. So, as you know, diabetes mellitus is very common nowadays because 9% of the population, they are suffering from diabetes mellitus. And almost 47% of the patient, they suffer some sort of peripheral neuropathy. Almost 7% of those peripheral neuropathy, they are from autonomic neuropathy. So it is very common, and this is one of the cause of death also. That's why cardiac complication is so much. So that's why we have to diagnose it early so that we can treat the patient. Coming to the risk factors, what are the risk factors of neuropathy? My presentation will about these following things: diabetic neuropathy, diabetic autonomic neuropathy, its pathophysiology, how to screen those cases early, what are the cardiovascular autonomic neuropathy, what are their risk factors, how they present, and how we can able to manage those cases. GI autonomic neuropathy, gastrointestinal, genitourinary autonomic neuropathy, other diabetic autonomic neuropathy. Coming to diabetic neuropathy, a spectrum of neuropathic conditions with clinical manifestation ranging from peripheral neuropathy to autonomic dysfunction, including cardiovascular, gastrointestinal, and urogenital. Despite advances in clinical care, it remains a highly common complication of diabetes. I want to say pre-diabetic state is not safe. So what are the complications which we know in the diabetic state? We know that pre-diabetic state also has similar type of complication. So we have to pick up those cases who are pre-diabetic. Now, how we can compare between different type of diabetic neuropathy. There are so many classification of diabetic neuropathy: asymmetric, proximal, distal, sensory, motor, demyelinating, actional. Out of these, I think these are the common classification we have to identify. Now, diabetic sensory neuropathy, that means large fiber and small fiber involvement. Now, small fiber involvement means pain, and large fiber involvement means position sense disturbance. So, if it is a diabetic sensory neuropathy, we will get both symptoms. But if it is a diabetic small fiber neuropathy, so those patients will present with severe pain. And the diagnosis of diabetic small fiber peripheral neuropathy is very difficult. In those cases, we have to measure the skin number of small fiber in the skin. So that can be done by intraepidermal fiber density. In case of diabetic autonomic neuropathy, which is our concern today, it is usually gradual, it is widespread autonomic involvement, may include orthostatic hypotension, cardiac autonomic dysfunction, gastroparesis, neurogenic bladder, and erectile dysfunction. And there are widespread autonomic failure. If we know that when a person is eating, in those conditions, there is sweating in the face. So why there is sweating in the face only? Because face, they are the small length fiber, but the limbs, that means where the sweating is less. So sweating is less in the feet, sweating is less in the hand, but compensatory sweating occurs in the face. So that's why when the patient who is taking meal, particularly food or cheese, there is excessive sweating in the face. So by that way, we can identify possibly some sort of autonomic involvement is there. There are lumbosacral plexopathy, we know diabetic amyotrophy, and also there are other form of diabetic neuropathy, which we are having not, particularly if we look for treatment, because some of the treatment itself can produce diabetic neuropathy. But remember, not that all the autonomic neuropathy in diabetes is not due to diabetes only, because we have to exclude other cause of peripheral neuropathy, although the patient is suffering from diabetes mellitus. So cardiovascular complication is one of the dreadest thing because there is chance of sudden cardiac death. So identification of this is very important. So in case of cardiovascular, next we come across the gastrointestinal neuropathy, esophageal dysmotility, gastroparesis, constipation, and diarrhea. Have low prevalence in contemporary cohorts. Now, urological complications, including sexual dysfunction and LUTS, lower urinary tract symptoms, are highly prevalent in diabetes, with an elevated risk of 50 to 200% in women and 25 to 300% in men. So risk factor for urinary incontinence in women are type 1 diabetes mellitus, in body, that means higher body mass index, in recent urinary tract infection, while for female it's a sexual dysfunction, psychosocial factor such as depression and marital status were predominant. In women with type 2 diabetes, prevalence of urinary infection is associated with age, diabetes duration, microvascular complication, and neuropathic pain. Because the pain means small fiber involvement. So autonomic fiber are small fiber. So it is when the patient suffers from painful neuropathy, most likely patient must have autonomic neuropathy also. So when a patient presents with painful neuropathy, so we have to test the autonomic functions. Now, what are the mechanisms of damage of nerves in diabetes mellitus? As you know, there are multiple pathways which is involved. Ultimately, there is oxidative stress, reactive oxygen species, and nitrogen species, and that produces inflammation. So possibly this inflammation, non-infective inflammation, which is causing the damage to every organ, including peripheral nerves. Now, what are the symptoms by which we can, when the patient comes to us, we have to ask few questions. And if these questions, they answer these questions, by that way, we can identify the patient have autonomic or not. Those are, if patients suffer from lightheadedness, dry mouth, feet are pale or blue, they are colder, their sweating of feet is decreased, they are sweating in hand and face, they are more proximal. That's why they are sweating is more than that. And nausea, vomiting or bloating, that means gastroparesis, and diarrhea, side-by-side constipation. Although constipation is more seen in diabetic gastrointestinal autonomic neuropathy. And leaking urine and difficulty in obtaining an erection. So these are the symptoms we have to ask the patients who are having diabetes for a long time, and to exclude autonomic neuropathy. Now, cardiovascular autonomic neuropathy, its prevalence is 17 to 73%, depending on clinical and demographic situation. So this can develop risk factor for type 1 diabetes mellitus. In type 2 diabetes, the multiple factors are there. What are them? They are obesity, they are hypertension, they are hyperlipidemia, and all these factors, we know that they are the risk factor for stroke, they are the risk factor for cardiac complications also. So insulin resistance, which underpin type 2 diabetes and metabolic syndrome, has a direct role in the pathogenesis of cardiac autonomic neuropathy. So clinical presentation of this patient, because we know the parasympathetic is a nerve for feeding and breathing. That means taking food and also reproduction. So parasympathetic dysfunction will produce the loss of peristalsis, so that means bloating, indigestion, and all sort of things regarding feeding, salivation, that is also altered. And regarding breathing, that means erectile dysfunction, impotence, they can all occur. And we know the sympathetic, that means fight and flight response. So that means tachycardia and all these things, exercise induced, they will be blocked when the sympathetic nervous system is disturbed. The parasympathetic system is affected fast, so leading to sympathetic predominance, which manifests as resting tachycardia. And as CAN progress, the sympathetic system also becomes involved, which lead to advanced signs and symptoms of CAN, such as orthostatic hypotension. So what are the how we will identify the orthostatic hypotension? There are very simple tests. The patient will say that syncopal attack. So changing in the positions, patient suddenly blackout sensation. So definitely we have very difficulty in diagnosing syncopal patient, whether it's a cardiogenic, whether it is epileptogenic, whether it's a vasovagal type of syncopal, but definitely patient will come with that. Now, what are the treatments? So there are many treatment options and many drugs are available also, including midodrine, doxidopa, fludrocortisone, pyridostigmine, atomoxetine, and octreotide. I think if anyone try with their own preparations, their own drugs, I think they can use it because all these drugs are available. Now coming to the diagnostic testing, what I feel, only the measurement of blood pressure is adequate. When the patient comes to chamber, they should take 5 to 10 minutes of rest. After 5 to 10 minutes of rest, they should be allowed to stand actively. And after 3 minutes, the blood pressure is recorded. When the systolic blood pressure falls below 20 and the diastolic blood pressure falls below 10, then we can diagnose the patient is suffering from orthostatic hypotension. But if this test is negative, we can ask the patient to sit and stand for 12 times, and then again measure the blood pressure. If the blood pressure falls with this type of grading, then we can think the patient is suffering from orthostatic hypotension. Now, there are so many other complicated tests, but I personally feel the ECG machine with the patient and patient in inspiration for 5 minutes, expiration for 5 minutes. So that means 5 seconds, inspiration 5 seconds, and expiration 5 seconds, and that means 10 seconds. And if we do a 6 cycle, it will cover 1 minute. And we will do that 8 cycle. So 8 minutes. So if ECG with the patient, and we look the variation of because inspiration increases the heart rate and expiration decreases the heart rate. We can calculate the heart rate. Usually in the younger age, the heart rate variation might be about 18. So inspiration, it will increase up to 18. But in 70 years and above, it might be 8. That much rise will not appear. So this testing of postural hypotension and variability of the heart rate, by that way we can diagnose. Obviously there are some other method by which we can diagnose that patient is suffering from autonomic neuropathy. Some of these are mentioned here. So resting tachycardia, heart rate cardiovascular test, heart rate variation I have mentioned, resting heart rate, QT interval. There are other tests, ambulatory blood pressure measurement. That can be done, what are the rise and fall of blood pressure. So some other test might be the QSAT. That means acetylcholine can be injected and the amount of sweating can be seen, and by that way we can know the sudomotor function. Usually there is disturbed thermoregulation in diabetic patient. That's why the diabetic patient feel very hot. And as the sweating is less, that's why sensation of hotness will be more. So that is the disturbed thermoregulation. Now, what are the drugs which we can use for orthostatic hypotension? We have mentioned there are midodrine, there are pyridostigmine, there are fludrocortisone, but for supine hypertension, we can use clonidine, we can use losartan, nifedipine, nitroglycerin patch, sildenafil. You know, sildenafil is used for other purpose in diabetes mellitus, and eplerenone. So among these, I think we know there are few drugs which we are accustomed to use. We can use that in supine hypertension. Now, what are the clinician encountered barriers in assessing diabetic autonomic neuropathy? So many a time patients feel asymptomatic, so limited methods of diagnosis, how to apply this type of diagnostic testing. Gastrointestinal autonomic neuropathy, symptoms are non-specific. Medication side effects can mimic. Urogenital autonomic neuropathy, no clinically available diagnostic test. So BPH, sometimes psychosocial factors, sometimes we can confuse whether it's a diabetic neuropathy or not. Now, cardiac autonomic neuropathy, its management focuses on symptomatic control, that means orthostatic hypotension, resting tachycardia, and strategy to delay progression or minimize cardiovascular risk factor. Now, there are some things here we have mentioned, that weight loss, diet, exercise, medications, blood pressure control, glycemic control, all can be given, and some behavioral strategy is also important, like for volume repletion, orthostatic hypotension, abdominal binder and elastic stocking, again for orthostatic hypotension. I have mentioned the pharmacological treatment. Now, coming to newer diabetic therapy may modulate cardiac autonomic systems. We know that sodium glucose co-transporter 2 inhibitors, that is dapagliflozin, they are available. What they do? Usually in kidney, sodium is excreted and glucose is absorbed. But here, they block glucose absorption. So excess amount of glucose is excreted to the kidney by these drugs. So these are some mechanisms how this SGLT2 inhibitor works. Now, these two drugs, they are available, and many of our internists, they are using this type of drugs, and they have good cardiac safety profile. They can be used both for controlling diabetes and also the cardiac complications. Another is glucagon-like peptide 1 receptor. We know that glucagon, only insulin decreases the glucose, but all other hormones, they are against insulin. And glucagon is one of that. But this glucagon-like peptide 1 receptor, they inhibit the glucagon release. They also increase the beta cell hyperplasia, so amount of insulin will be high. So they increase the beta cell also. By that way they are functioning. There should be only the caveat that they can produce gastroparesis. So that's why in those cases they cannot be used. Now they are combination of SGLT2 and also T1DM. they can be used for benefit. Now, cardiovascular autonomic neuropathy in diabetes, their pathophysiology has been mentioned in short. There are inflammation, there are insulin resistance, dyslipidemia, genetics, some altered genetic status, mitochondrial dysfunction, collagen turnover. Now, diagnosis can be done by questionnaire, heart rate variation, cardiac autonomic function testing, ambulatory blood pressure monitoring, and they can be controlled by some wearing devices. Now, management, weight loss, diet, exercise, bariatric surgery, medication, and symptomatic treatment. So, GI autonomic neuropathy, it usually produces decrease, that means reduces peristalsis, because you know the parasympathetic function is that function which increases the peristalsis. So, esophageal enteropathy, again, this prokinetic will work, because if you hang a person head down and leg up above, patient can swallow. How they are swallowing? Because of the esophageal motility. If the patient is taking head down position and leg is above, if he is taking food, the food will go to stomach. So that means if esophagus is decreased motility, by giving prokinetic drug, you can increase the progression of the food inside the intestine. So gastroparesis, there are constipation, side-by-side diarrhea, so it's very difficult to control. If you try to control constipation, the chance of diarrhea will be there. If you control diarrhea, the chance of constipation will be there. But you have to tackle both, and there are treatment options for both also. So fecal incontinence, gallbladder atony, and enlargement.
Sir,
So
if you
all
please conclude, we are
are due
running.
to, yes, motility. Now, if it's mild symptoms, it can have some nutrient delivery, because patient wants to take food. If the food is not digested, if it is impacted in the stomach, so this discomfort will bother them very much. So constipation, there are a lot of things, investigation we can do, but we can ask how many times the stool is passed or not. Usually by that way, and also consistency of the stool. Diarrhea, this is another, because of the bacterial flora, and they are increasing in number because of less amount of motility inside the gut. So organ manifestation, we already know. So there are some advice by which we can control this. So diabetic gastropathy, we can use the prokinetic drugs, various type of antiemetics. There are also some invasive method. So how to diabetic cholecystopathy, diabetic diarrhea, we can use the bulking agents, because they will take away the fluid material from the stool. That's why they can, and loperamide, cholestyramine, clonidine, octreotide, there are subcutaneous injections that can be given. So if there is pancreatic insufficiency, pancreatic enzyme can be replaced. So genitourinary autonomic, that's part. So we have to take the sexual history. You have to take the initially for bladder dysfunctions, we have to do that. There are anticholinergic when the bladder is overactive. There are beta-3 adrenergic receptor agonist, mirabegron, that relaxing the muscles. So by that way, when the hyperactive bladder is there, because acetylcholine, they produces contraction of the bladder and relaxation of the sphincter. So it is the evacuation. So parasympathetic is the evacuation part. So if the parasympathetic overactive, then anticholinergic will help. And also the beta-3 adrenergic receptor agonist will help. So likewise, when there is atonic bladder, we can do self-catheterization. Obviously, suprapubic cystostomy that can be used. For erectile dysfunction, there are sildenafil, tadalafil, and vardenafil. The advantage of tadalafil is that it can work up to 36 hours. So means a man can be ready after 30 minutes, and up to 36 hours he should not have to take another tadalafil because it is 36 hour active. For sildenafil, it is 4 hours. For vardenafil, it is for 5 to 6 hours. And the sildenafil disadvantage is that it also blocks the phosphodiesterase 6. That means color information will be not there. So he cannot be able to interpret the color. So that is the things. And obviously there are other advanced therapy for erectile dysfunction that can be done. Now, there are different type of stages. These are the advanced stage where intracavernous injection, Doppler, cavernous, these are that can be given. Hope for the best that we do not need all this type of thing if we treat the autonomic neuropathy very early. So what are these are the things which have to control. So sweating, we can use topical agents. For anticholinergic drugs, topical glycopyrrolate. For pupillomotor, it do not need that, but danger of glaucoma is there. And for respiratory system, continuous positive airway pressure. So that means many of the patients may suffer from obstructive sleep apnea. So CPAP will do wonder. So coming to the summary, diabetic autonomic neuropathy, serious, systemic disorder, most studied for cardiovascular functions. Once DAN becomes clinically provident, no form of therapy has been identified. Prevention is the best method. Newer drug like that of SGLT2, I usually remembered it, sodium glucose transport, so inhibitor. And also GLP, that means glucagon-like peptide. So thank you for your kind attention. Thank you very much.
We have our another chairperson with us, Dr. Dilip Dotto, a renowned consultant, physician, neurologist and neurosurgeon attached to Narayana Hospital, Howrah, along with Dr. Somnath Nashkar.
Okay, thank you, sir, for a detailed discussion. So for time constraint, we can allow only one quick question, please.
Sir, if you have any comment, because you are practicing for a long time, you are dealing with at grassroots level, I think you make some comment or questions also.
So it is found that cardiac complaint developed before diabetics, frank diabetics.
What?
Frank diabetics. Suppose I diagnose a case of diabetes today, but cardiac problem developed before that. Right? So you also say the autonomic neuropathy also same time. So there is any test along with when we diagnose type 2 diabetes, then there is any test for this? So usually we do after 5 to 10 years after diagnosis of type 2 diabetes. But at the time of diagnosis of type 2 diabetes, any test for this or need for test of the autonomic neuropathy?
So I think every diabetic patient, whenever they are coming to our clinics, particularly having painful neuropathy, they should be tested for heart rate variability, they tested for postural hypotension. and test for sweating of the distal part of the limbs. So if there is autonomic involvement is there, there is chance of cardiac autonomic things is also there. So we have to monitor the cardiac function also.
Any other question or comments? Thank you. Thank you for such
Thank
an
you,
elaborate
Speaker.
presentation on such an important topic.
Thank you, everyone also. And also, INTAS has done to the logistic things has done by those group. Thank you also to them. Okay.
Thank
So
you,
it closed
sir.
the
We are
session.
honored. Thank you, Speaker. Thank you, Chairperson. It's time to facilitate our Speaker and Chairperson. Sir, please be there. I would like to request Dr. B.P. Pandey to please felicitate our Speaker and Chairperson on behalf of HDS.